So last time we had stopped here. So let's look at biaxial joints. Okay, so movement is possible in two axes. It could be any two. It just so happens that in biaxial joints, the kind of movement that you see is just these two combinations of movement. So you see flexion, extension, and you see abduction and adduction. These are the only two kind of combinations. If you remember, flexion, extension was along a transverse axis. And abduction, adduction was along an anteroposterior axis. So that's why it's biaxial, two axes, okay? Transverse and anteroposterior. And the joints we find in this, the joints are called condyloid joints. So there are kind of oval articular surfaces you can see. So this one is kind of raised and the other one is hollowed, but they're both oval. And here you can see, so this is along a transverse axis, flexion and extension. This is along an anteroposterior axis, abduction and adduction. So can you see that? Examples of this joint are the wrist joint, okay? This part here, the lower end up here at the wrist. So this is where the radius would be. The wrist joint is formed by the radius and the carpal bones. The ulna does not participate in the wrist joint. So I'm going to remove the ulna and put it separately. So this area here at the wrist joint. And if you look at it, what can you do in the wrist? So if I was to draw the wrist joint, so at this joint here, what can you do? You can flex this joint and you can extend it. You can do flexion and you can do extension, right? Flex when you take your palm towards your forearm, flexing and extending when it's moving away. So that's flexion, extension. And then when you take the wrist towards the midline, that part is adduction. And you take it away from the midline, that is abduction. So this is adduction and that is abduction. And the way you can remember it is put both your wrists side by side, flex them. So you can see flexion was a movement where the angle decreased. So you can see this angle is decreasing. Extension is the opposite movement where the angle increases. So this is extension. Adduct, bring both wrists together. So you can see add as you're adding. So this is adduction. Abduct, you're taking it away, right? So you can do these two sets of movements. And when you sort of turn your wrist around like that, that movement is circumduction. It is not rotation, okay? When you kind of, what you think is rotation is that if you turn your palm down, which is this way, sort of in your forearm, when you turn your palm down and when you straighten it out like this, that movement of supination, pronation, remember, doesn't occur at the wrist, but it occurs at the radioulnar joints, right? So the wrist, you can only flex, extend, adduct, and abduct. So this is the movement, and this joint is called the condyloid joint. The other example of a condyloid joint is this metacarpophalangeal joint as shown here. And one way to remember metacarpophalangeal, MP joint, is the knuckle joint. So again, at the knuckle joint, what can you do? So if you look up here at your knuckles, so put your fingers on your knuckles and flex. So, you know, when you flex, you kind of curling your fingers towards your palm. That's an example of flexion. You can feel the movement at the knuckle. And you extend when you uncurl your fingers. And abduction, if you remember, was when you spread your fingers, right? That's abduction. And adduction is when you get them together. So that movement occurs at this metacarpophalangeal joint, okay? So flexion is curling your fingers into your palm. Extension is when you uncurl them. Abduction is when you spread your fingers apart. Adduction is when you get them together. At the metacarpophalangeal joint and in both the feet and the hand, the adduction and abduction is not towards the midline, but an imaginary line which passes. In the hand, it passes through the third finger. In the foot, it passes through the second toe. When anything moves towards this third finger, we call it adduction, which is when you get your fingers together. And when anything moves away from this third finger, we call it abduction. So when you spread your fingers, that's abduction, okay? Or spread your toes, that's abduction. So that's why the wrist and metacarpophalangeal are examples of condyloid biaxial joints. There's another joint which is very similar to a condyloid joint. It's called a saddle joint, and it's called saddle because of the shape. It looks like you're sitting on a saddle, and if you look at this picture here, see, this is the saddle and this is the bone sitting on top. Can you see both surfaces? One surface is convex, one surface is concave, and fits in well. And the joint, which is a perfect example of this saddle joint, is this joint between the carpal bone and the first metacarpal here. So this joint, which is called the carpo-metacarpal joint of the thumb. So it's in the thumb. The carpo-metacarpal joint of the thumb. And this joint is at the base of your thumb. So the movements are very similar to condyloid, which is if you look at your finger, you can get your finger across your palm, which is flexion. You can take the finger away from the palm, which is extension. The difference being when you get your finger across this thumb, across your palm, there is, along with flexion, there's a slight degree of medial rotation. I don't know if you can see it, but if you look at your thumb, you can see there's a slight degree of medial rotation. When you take your thumb away from the palm, there's a slight, which is extension, there's a slight degree of lateral rotation. So there's a little bit of rotation which accompanies these movements. And adduction is when the thumb lies against the lateral side of the forefinger. When the thumb lies against the lateral side of the forefinger. And abduction is like when you make an L like this. Okay? So again, flexion, extension, adduction, abduction. But the little more range was that when you're doing flexion and extension, you had that little added rotation. So that's why there's a bit of range. But it's not, some people even classify it under polyaxial. I don't. For the simple reason that the rotation is not a separate movement. It is an accompanied movement. Okay? Then lastly, we have multiaxial joints, where we have joints which can perform movements in all three axes. So if you look, they can do it in this transverse axis, which is flexion extension. They can do it in this anteroposterior axis, which is abduction, adduction. And they can do it in this vertical axis, which is rotation. So remember, rotation occurs along a vertical axis. Abduction, adduction occur along an anteroposterior axis. And flexion, extension occur along a transverse axis. So multiaxial joints are also called polyaxial joints, which are ball and socket, where you have a socket into which a rounded spherical head fits like this. This is a good example of a ball and socket. At the shoulder, if you remember, we had the glenoid cavity in the shoulder, the glenoid cavity of the scapula, and fitting into it was the head of the humerus. So that's why the shoulder is often also known as glenohumeral joint. The shoulder is also called the glenohumeral joint because glenoid cavity of the scapula and the head of the humerus, glenohumeral joint. So that's the shoulder joint. In the hip joint, it was like the glenoid. In the hip bone, you have the acetabular cavity. So it was the acetabular cavity of the hip bone. And it was here the head of the femur. We don't have something called femoroacetabular, but you can think of it that way. I mean, that's not a usually used term. Okay? Acetabulum of the hip bone, acetabular cavity or acetabulum, it's the same thing. So we call it glenoid fossa or glenoid cavity. Same way, acetabular fossa or acetabular cavity and the head of the femur. So here, since movements are possible in all planes or all axes, so you can flex and extend, you can abduct and adduct, and you can rotate. You can do medial and lateral rotation. So in the case of the shoulder, when you flex, you take your shoulder across your body like this. So the angle between your body and the shoulder and the humerus decreases. Extend, you take it away, backwards like this. Abduct is when your arm moves away from the body. Adduct when it moves to the side of the body. And rotate. Rotation is where the anterior surface, when it rotates, when it moves towards the median plane, we call it medial rotation. So you always have a point. So if you keep your finger on the front of your shoulder, on the anterior surface, and twist your shoulder like this, you can see it moving medially, and do the opposite, moves laterally. Okay? So medial and lateral. Medial is also known as internal rotation. Lateral is also called external rotation. So all three movements are possible at this ball and socket joint. Most mobile joint, which is why you remember we saw so many bursae. Remember those bursae were synovial filled sacs.
So when you're doing,
Ooh, okay.
When you're doing pronation and supination, are you automatically moving your shoulder at the same time?
Well, the limbs do not joint because of the attachment of various parts. When you do pronation and supination, you can hold your arm and then just do pronation and supination. If you keep your arm by the side of your body and then you do pronation, supination, you might find a slight movement. So they can be separate. Okay, ball and socket, yes, numerous bursae. Wherever there is a lot of movement, that's where you want bursae. Because what is the function of a bursa? To prevent friction. So in a plain synovial joint, which has very little movement, because just gliding movement, why would you need bursae around that, right? It's not going to move too much, isn't it? Imagine, think of it. Where are you going to post security guards? Think of these as protective, right? Security guards. In a place where a lot of activity is going to take place, or somewhere where very little activity is going to take place? Obviously, in somewhere where a lot of activity is going to take place. So along ball and socket, which has the maximum movement possible, because it moves in all three axes, all movements are possible. Okay. Secondary cartilaginous joints they're amphiarthrotic, they allow slight degree of movement. And an example of a secondary cartilaginous joint was? Secondary cartilaginous joint, example. Intervertebral joints. Yes, the joints were between the vertebrae. Remember, they were midline joints. So were the intervertebral joints. The pubic symphysis was another one between the two hip bones, again in the midline, and the joints between the three pieces of the sternum. Yes, right? Midline. So that's how you're going to remember, okay? So very little movement. And fibrous joints, no movement at all. Remember, yes, in syndesmosis and the gomphosis, I said slight movement was possible at certain times. But that movement is so very slight, which is why we put them all in the immovable category, right? So you don't need bursae around them. And think of it, where the tooth in the socket, where are you going to have bursae there, right? There's not enough space to do that. Okay, of these, which joints have the greatest degree of movement? Now everybody should get this right. Ball and socket, yes, plain, very little, just gliding. So not greatest degree. Greatest is ball and socket. Now here let's look at some joint conditions. The first one, which many of you have heard, some of you may have suffered from it, is where a ligament gets torn. And most of the time ligaments get torn wherever they are weak and at joints where a lot of movement occurs. The ankle is one such joint which is prone to tearing of ligaments. And it's on the lateral side, so the ligament is completely torn in this case. Sometimes the ligament may be stretched or just partially torn. In any case, we call it a sprain. And why more in the ankle? Because the ankle, when you're walking on uneven ground, as you can see here, when you twist your ankle. And can you see when you twist it, there is a lot of the lateral side of your ankle will be stretched. And this ligament present on the lateral side of your ankle is a little weak. So naturally it gets torn. Okay, so that's why ankle injuries are common in where you have ligament tears. Ligament, whenever there's a ligament tear, it takes longer to heal. Why do you think that's so? Poor blood supply. Yes, very good, because ligaments are dense, regular connective tissue, right? And the blood supply is not so good. Muscle has better blood supply than ligament. So wherever there are tears in the ligament, it takes a little bit longer to heal. Then we have situations in bones where the bones, which were normally articulating together at any particular joint, then they cease to articulate because of some force or the other. So there is no articulation at all. So such a situation is known as a dislocation. So good examples where dislocations occur are this shoulder joint. Remember when we did, when we talked of the shoulder joint, and you saw it was the glenoid cavity and the head of the humerus. Now the glenoid cavity is very small, as you can see here, and the head of the humerus is rather large. Okay, so this joint, because you have a small cavity and a big head, can you understand it's not a very stable joint? But this joint is extremely mobile, because you know that you can do a lot more at your shoulder than you can do at your hip. Because in the hip, the acetabular fossa kind of grips the neck of the femur quite securely. So that joint is very stable but less mobile. Okay. So in the case of the shoulder joint, the head of the humerus can completely come out of the socket and they no longer articulate. So if this is the glenoid cavity, this is the head of the humerus as shown here. It's lying in front. So they're not articulating at all, and that's called a dislocation. Okay. Dislocations can also occur at the acromioclavicular joint. Sometimes in contact sports, at the acromion and the clavicle, at this point here, you can see this is where the acromion and the clavicle normally articulate. In contact sports like football and so on, imagine somebody comes and either hits you from the back or hits you from the front. What will happen? The clavicle moves away like this, and here is the acromion. So previously this is how they were articulating. But now the acromion has been pushed away and the clavicle is here. So can you see they are no longer articulating with one another? So that's a dislocation. Okay. So these are some areas where dislocations are common. As in comparison to a dislocation, we have something known as a subluxation. Subluxation means where the bones are still in contact with each other. They are not completely away from each other, but the contact is not right. So they are misaligned. So to give you the same example, if here I showed you a dislocation where the acromion and the clavicle are no longer in contact, no articulation. In a subluxation, if this was normal, this was the normal place where they were articulating. In a subluxation, what would happen would be that they are pushed out of alignment, but they still make contact with each other. Can you see they are still in contact, but it's misaligned. So they move away from each other, but still touching at some point. So that is known as a subluxation. And the acromioclavicular joint is again one of those joints which tends to subluxate quite frequently, again because of contact sports, which is why they wear these heavy shoulder pads. Here is another example of a subluxation. Look at all these vertebrae. They are aligning normally. Can you see they're sitting one, articulating normally with one another? Look at this part here, where you can see this area here, where you can see that the bones are still touching each other, but they are not articulating properly. This should have been in front, but it has been pushed back out of alignment, so misaligned. Do you have a question? Yeah. How would you fix that? Whenever there's any part which is subluxated, in the case of a vertebral column injury, you'll have to do traction and something like that and push it back. If it was a joint like the acromioclavicular, you'll have to reduce it and get the bones back into alignment. Okay? You can't leave it like that. You have to get them back into alignment. Yeah. Sometimes it might require major surgery, sometimes not so. And we saw right now anything to do with joints, we use the word arthro, like see diarthrotic joints, synarthrotic, right? Amphiarthrotic. So whenever there is inflammation, we use the word itis. So inflammation of a joint is called arthritis. There are different types of arthritis, you may have heard of, yes, RA, rheumatoid arthritis. In rheumatoid arthritis, this is an autoimmune disease where the body is actually attacking itself, and what it does is it attacks the synovial membrane. So the synovial membrane thickens and there's something called a pannus which forms, and it's very painful. It's extremely painful, and it affects the joint properties. You can just kind of try to delay the progress of the disease. You can't completely cure it. It can get so bad that after some time the people lose, and it usually tends to affect small joints, so they lose the function of that joint. So when it affects your hands and feet, usually their hands can get kind of really, malformed, and it's quite a painful condition. As opposed to that, we have a condition which is known as osteoarthritis, which is an old age wear and tear kind of arthritis, where here, and I've referred to it often, remember the articular cartilage? That kind of gets worn out. So bone is rubbing against bone, and you get whenever there's friction like that, you get little bony spicules or bony projections which form, and that becomes painful because, again, it's bone rubbing against bone. What's the difference between osteoarthritis and osteopenia? Osteoarthritis is an inflammation of the joint. Penia means less. Osteopenia is a precursor to something called osteoporosis. Osteoporosis is a condition where the bone density decreases, where the amount of bone that is formed, or the bone removal overtakes bone deposition, so the bone becomes less dense and more brittle. Osteopenia is a precursor, means you have less density, but you haven't reached the a stage where you're osteoporotic. Okay, so it's just before osteoporosis. Then we have a condition called gout. Gout is where uric acid crystals are deposited, and this it's deposited within the joint cavity. So it inflames the joint because these are crystals. They irritate the joint and cause inflammation. It tends to affect the great toe. The great toe is the one, the big toe is the one, and it's this metacarpophalangeal joint of the big toe. That's the area which is usually affected. You can see a big swelling in that area. It's red, it's painful, it can come on at certain times. Usually this is because of diet. Certain substances tend to make gout worse.
Does that go up throughout your foot, or can it go?
It can go to other areas, but this is the one that is most affected, the big toe. Okay, so let's look at some videos on this. So let's look at dislocations.
With the humeral head displaced in a subcoracoid or subglenoid position, the spasmic biceps tendons bowstring across the humeral head, lateral to the axis of the displaced head, so keeping it out. Therefore, humerus held in the correct position, relaxation of the biceps should allow reduction to occur. The biceps is actually massaged distally to the joint around the midshaft of the humerus. As the muscles relax, the humeral head falls in.
So this answers your question, like what you do when something like this happens. So you can see this, there's no surgery required. The shoulder joint tends to dislocate fairly frequently in some people. Usually when it dislocates once, it can occur again. So what they do is they kind of just relax the muscle and they push it back. And after some time, the patient themselves know how to kind of push it back, So you don't need any surgery. Sometimes when it's really bad, you might require surgery. And as you saw in that video, you saw the head of the humerus was no longer in contact with the glenoid cavity at all. So that was a dislocation. So let's look at a subluxation. So here it's showing you the vertebral subluxation. So it's kind of misaligned and goes back like that, the nerves, and cause. So here there's lumbar subluxation. So can you see? The bones are still articulating but not properly. So there's misalignment. They're not completely out of contact with one another. So that is sublux, a little bit gout.
doctor, our question is, how does gout affect your foot? Now, gout is an inflammatory arthritis caused by acid in the foot. In the big toe, sometimes in one of the midfoot joints, and I've seen it a few times here and there in the ankle, although the big toe joint is most common. Usually the patient comes of a red hot swollen joint, and a good history and sometimes some lab work or a joint tap to test for gout-like crystals under a microscope. One of the differential diagnosis might be an infection of the joint, so it's important to confirm the diagnosis of gout. Besides having short-term gout attacks, which can last for a few days with a red-hot swollen joint, gout destroys your joints in the foot long-term. It has extra erosion, which almost looks like rat bites X-rays. And this can lead to long-term foot dysfunction, and also in the soft tissue, something called a tophi, which is a deposit of uric acid can build up, and sometimes these can be surgically excised. Any questions regarding gout in your feet?